case scenarios I will be discussing with a special reference to transthoracic and transesophageal echocardiogram. So the role of imaging in AHD, as all we know, is helps us in accurate anatomical assessment in different views. We understand the margins and size of the AHD. We get an idea about degree of pulmonary hypertension, how much is the level of shunt, that is the overall assessment, the right ventricular and left ventricular function. If there any additional defect, like associated pulmonary stenosis, or there is any anatomical variation like bands, which is not very uncommon in case of AHD in small kids. AHD imaging has an enormous role during the transcatheter management, where the difficult AHDs are require help of transesophageal echocardiogram. I'll show some cases where the balloon occlusion study and balloon sizing, which help to know the AHD better and treat that, and post-operatively definitely it will be of use. So the first case is an AHD in a younger boy. So this first case one I am showing, this is in the subcostal view. We can appreciate an aneurysmal inferior margin, and there are two holes. The superior one is the big hole, and inferior one is a small hole. So two issues in this small child is aneurysmal AHD and two holes with a bigger hole superiorly. So this is a frozen image of the same. The superior hole measured approximately 22 millimeter, the smaller one 8 to 10 millimeter, and total length. So this actually, the AHD runs from this inferior margin to that margin. It's frequently difficult to exactly decide on the size of the AHD based on the floppy margin, because we will be banking more on the solid margin. So we took the child in the cath lab, and in cath lab a detailed transesophageal echocardiogram done to delineate. So this is in the 90-degree axis view. This is RA, this is LA, and this is the superior vena cava superior margin, and we can appreciate this is the larger superior hole, this is the smaller inferior hole, and there is a significant amount of tissue, but it is floppy type. So we decided, because it is a floppy tissue, which will allow us to put a big device in the superior hole, and thereby we'll be able to push the septum more inferiorly, and it will be possible to close the defect. So here the most important part was crossing the AHD through the upper AHD, and that required T guidance. So you can appreciate we have this catheter, and that catheter was crossing the superior hole, and that fact has been confirmed only on transesophageal echocardiogram, and that is the key point in the closure. So here we took a 28 millimeter atrial septal occluder in the right upper pulmonary vein approach with wire support. So another wire and catheter is kept in the left upper pulmonary vein, and under T guidance we close the defect. So this is post-procedure, a stable device. You can appreciate all the margins spot well. And in the inferior there was small residual, which was not considered very significant, and that same thing came down in 6-month follow-up. So this illustrative case is an proof for utility of detailed transesophageal echocardiogram or additional imaging in case of difficult AHDs. The second patient is a 54-year-old gentleman with a class 2 effort intolerance, exertional palpitation, and he detected to have a large atrial septal defect. So, has increased pulmonary blood flow in X-ray with ECG showing right axis RBBB pattern. So, again, a transthoracic echo, the measurement as we commonly see in the 4-chamber view or in short axis was not coming more. It was around 28 to 30 millimeter only. But in adults, we always embark and we do a pre-procedure transesophageal to know what we are dealing. In the subcostal view, we were seeing a deficient superior margin and inferior margin was floppy. This is the subcostal view, this is LA, this is RA, this is the part of the IVC and this is the inferior margin we are seeing. My arrow is there. That was little floppy. And here in the frozen image, I have just tried to get, it's a big HD, but there is a small dip of the color. And that color was the hope color, because it was telling we have some margin. So in transesophageal echocardiogram, the maximum dimension we got 38 millimeter with floppy inferior ring. You can appreciate this is nearly 90 degree with little modification, superiorly, inferiorly, and this is that inferior floppy margin. In the frozen image, we can appreciate the same. This is in the 0 degree pure error. So the options were cardiac catheterization, knowing the coronaries and surgical intervention, bar, CAG and device closure. The patient opted for, after detailed counseling about the procedure, both cardiac surgery and cath discussed. Patient opted for transcatheter remedy. So we informed the surgeons, they are kind enough and kept the OT free for us, because there was a risk that if we are taking the device may embolize. So the good part, the peer pressure was normal in this gentleman with a mean of 13, and left ventricular end diastolic pressure, which can be high in that age group, was not elevated. The coronary artery was also normal. So all these are the 3 checklists for any patient in the adult. When we are trying to close a large hole, we should ensure we are fine in this category. So, equalizer balloon used and a balloon assisted device closure was planned. Now here we had a 38 millimeter hole, so we had to request and specially order a tailor-made 46 millimeter LifeTech atrial septal occluder. Here again, transesophageal echocardiogram was key, because we wish to have this balloon in position. Unless we confirm the position of the balloon in the right place, we cannot deploy the device. So this is a 46 millimeter custom-made AHD device from LifeTech, balloon assisted and nicely sitting or getting deployed. And this post-release, you can see the bulky 46 millimeter device completely occluded, no residual flow, was discharged on aspirin and clopidogrel. Now it is not 2-year, rather 3-year post-procedure. He is doing extremely well. And the device, which was so bulky in the 6-month time, came down in a very normal profile and the heart reorganized itself. So again, the transesophageal echo came in big way in helping us treating that patient. This is an interesting patient where again I'll discuss how the transesophageal and detailed evaluation helped us to come to a decision. 46-year-old lady, known case of AHD with a saturation 98%, significant effort intolerance, and admitted with respiratory symptom. Now, one interesting part of that X-ray I wish to highlight is significant dilatation of the MPA. And overall, the periphery, the vascularity was not that increased as I expect it to be, though cardiothoracic ratio increased 2.67, which may be part of dilatation of the RA. So ECG showing sinus rhythm with right axis, RBB pattern. Now this AHD was again a big AHD, 36 millimeter with bidirectional shunt. There was mild pulmonary stenosis, but the TR jet was not very good. So the grade of the pulmonary hypertension, I was not sure because there was some bidirectionality involved, RV dilated with dysfunctional and IVC congestion. So all these things were not looking very good that this hole is devisable or closable. We wanted to interrogate the same in cardiac catheterization. So RA mean pressure was 16, PA pressure systolic 16 with a mean of 30, and aortic pressure mean of 90. When we calculated this QPQS, it was coming 1.5. So the pulmonary blood flow was not very significantly elevated. The PVRI calculated was not high because the PA diastolic pressure was low, but overall PVRI SVRI ratio in the presence of less shunt was not very looking good. We decided to test occlude the AHD with a 33 millimeter equalizer balloon. And here again, the TE was helping to know whether we have stopped the flow across. The LVEDP, which was 30, jumped to 40 and patient developed symptoms. So you can appreciate the very high LVEDP in that patient. So that was telling the patient will not tolerate the closure and we should not embark on closing the defect. So in view of severe left ventricular diastolic dysfunction, intolerance to balloon occlusion, we decided not to close the AHD and keep her on medical follow-up, and TE-guided balloon occlusion and hemodynamic assessment helped in this decision making. The next patient, this is a very interesting patient I am now trying to share. A 27-year-old lady who was referred for device closure of a 25 millimeter secondum AHD. The RA and RV we can appreciate was dilated. So the RA-RV was significantly dilated. Regarding presence of AHD secondum, there was no doubt. But when I was doing the subcostal image, the size of the AHD was not coming very big. If we see the two dots are between 10 millimeter, this was around 10 millimeter or 12 millimeter maximum. So this secondum AHD, which I felt is not more than 10 millimeter or 12 millimeter in size, was unable to explain the degree of right ventricular dilatation, and that was the catch. So I decided to do transesophageal echocardiogram and I got surprised. And what was the surprise? 0 degree, I am showing very high, and we can appreciate there is an additional AHD, and this is basically sinus venosus AHD. I'll just come again. This is in the 0 degree, this is in the 90 degree, and here we can appreciate in the 35 degree, one red flow is coming. This red flow is the flow of right upper pulmonary vein. So we are dealing with a case. In addition to the secondum AHD, we have sinus venosus AHD. So what was happening in this particular case? Now in 125 degree, I could open both the defect. You can appreciate this is the RSVC, this is the septum, this is the aorta, this is the regular, I'll just, regular AHD, what we were seeing is around 10, 12, 15 millimeter. But there is a huge sinus venosus AHD above, and these two in combination was the reason for RV dilatation. And once we have found an additional large secondum AHD ostium, sinus venosus AHD, the case no longer is favorable for any transcatheter regular intervention, though nowadays we are trying a little bit. So it was sent for surgery. So again, when I came back and tried to see where I missed, and because I knew by the time that there is an additional hole, so on very careful interrogation I could observe is sinus venosus AHD. So I myself did that AHD interrogation initially, but this was very difficult to get. TE helped to reach to the diagnosis, and finally, this you can appreciate in three-dimensional TE. This is superior, this is inferior. We are seeing from the RA side, this is the secondum septum, secondum AHD, and this is the sinus adenosus AHD. So this interrogation helped completely change the directive of the treatment. And the last AHD series patient I wish to share is a 49-year-old lady, functional class 2, AHD, pulmonary hypertension. She was diagnosed and she was suggested surgery, but she had faith in one of my colleague, Dr. Dilip. Her Gurudev told that to go to Medica in our hospital to get treatment. This is something little bit of divine. So how divine things help? Again, in X-ray is cardiomegaly, PA dilatation with increased flow. We can see the end-on vessels. So in transesophageal echo, transthoracic echo, we got 30 millimeter AHD with moderate pH. You can see RVSP 40 plus RA. RARB significantly dilated. In the subcostal view, we can appreciate this is the IVC, this is the SBC, and it is a huge hole. And here I was not very sure that the IVC rim is very good. It was looking little more risky that whether we should attempt, because here I was not being able to get a nice inferior rim. In the transesophageal echocardiogram, I could appreciate there is a small nubbin of tissue in posteriorly. This is in 0 degree view. This is RA, this is LA, and this is a posteriorly small nubbin tissue. In the 90 degree, I could appreciate there is a floppy margin, very thin IVC rim. The HD was mainly left to right. So 3D and 2D in combination, finally 36 millimeter AHD with floppy and deficient posterior-inferior rim. So this was again a very challenging case in an adult lady with mildly elevated pulmonary pressure. So on cath, we found the pulmonary pressure rather more than echo, 68-28 with a mean of 44. LVEDP was 28 to 30. So I just wish to compare the last patient, what I showed with this patient, that similar type of pressure, but here one thing changed, and what changed is the QPQS. QPQS was 3 here, unlike the last patient, which was 1.5. So here, this was the reason we decided to attempt that case for device closure. The PVRI was 3.7, CAG was normal right system. So in view of elevated LVEDP, planned for fenestrated AHD device closure of 40 millimeter amplage. So you can appreciate this is the device, and 5 millimeter around fenestration created inside that AHD by cutting the fabric and expanding that region. So we deployed under balloon assistance here and stable device. We can appreciate some flow in the next. I think the good part of the story, the PA pressure, which was 68, post-procedure came down to 40, and LVEDP also from 28. Usually we don't take the high LVEDP, but reduction of the LVEDP and PA pressure with patient remaining stable, we decided to release the device. So stable device, pre-discharge, you can appreciate the PA pressure here coming 25 plus RA. And this is that fenestration's flow. You can appreciate small fenestration, but it was not shunting very well. The purpose was to immediately bail out in case of any difficulty. We did not or had not any trouble in the post-operative, and 6-month follow-up, she was doing excellent. And so this is the pre-discharge image of the lady, discharged on aspirin and clopidogrel. So In conclusion, I wish to tell imaging in ASD, transthoracic is less invasive, adequate in good windows, particularly in small kids. But in the adult, we need TE, which help us with more detailed evaluation. It is required for large and difficult ASD like multiple ASD, deficient and floppy margin, ASD with band, balloon occlusion and assistance. TE and transthoracic both basically complement each other in the difficult gray zone type cases. And in adults, mandatorily, we do a preoperative transesophageal echo to have a preferable outcome. So I'm happy